viewers, welcome to this week's episode of Healthwatch on Advent Cable Network Nigeria. I am Angela Emeka Ebibo. Hormones are chemical messengers produced in the endocrine gland in your body. They are powerful and can travel around your bloodstream, telling tissues and organs what to do. They help control many of our body major processes, including metabolism and reproduction. However, sometimes there may be imbalances in this hormone. Sometimes you may have too much or too little of a certain hormone, and this can cause serious effects throughout your body, even with a tiny change. In women, these changes can cause serious discomfort and sometimes causes difficulty in getting pregnant. On the program today, we shall be discussing some disorders resulting from imbalances in the female hormone. My guest today is a very popular guest on this program. He's Dr. Nathaniel Adewale. He's a consultant gynecologist at the University of Abuja Teaching Hospital, of course, here in Abuja. You're welcome to the program, sir.
Angela, nice being here once again.
Thank you. And thank
Hello,
you.
viewers.
Yes, and thank you so much for coming on the program.
Thank you.
Anytime I call you, you're always ready to come and share your knowledge.
It's our responsibility.
Yeah, thank
Part
you.
of the social corporate responsibility.
Of course.
Thank you.
Thank you so much for coming on the program. So today we want to talk about hormonal imbalances in women. Now, somebody will say, oh, you women, I'm very passionate about women because I want everybody to be, and I'm sure you are.
Of course, that's why I decided to choose it as a profession that takes care of women.
Take care of women. So I'm glad you are, and you're very passionate about it. So that's why you're the right person to call. So today we want to talk about hormonal imbalances, and we found out that hormones generally, they affect the processes in the human body, just like we said in the introduction, which I believe you agree with.
Yes.
So, but if there are changes, it could cause problem in women. So we've talked about the definition, but I want to know, we're going to talk about some disorders, but want to know generally what are some of the symptoms that a woman will notice and will say, oh, something is not right, your hormone is not, at least I know there are two major hormones, estrogen and progesterone in the body. So those ones I know they're the power, the control house. But what are some of the symptoms that we see and we say, okay, go and check, there's a problem here?
One of the things that really makes a woman is the monthly cycle.
Okay.
That's the menstruation.
Okay.
So one of the commonest symptoms is when there is abnormality in menstruation, either in terms of number of days of flow, interval between the flow, or the quantity. That's one of the commonest. There is usually there could be what you call delayed menses, or what we call oligomenorrhea, when there is the menses delay beyond the normal, or sometimes when there is complete absence of menses at all, when it is not due to pregnancy.
So what do we consider as normal days for a woman's pregnancy?
For a woman,
cycle?
A normal menses actually lasts between 3 to 8 days.
Okay.
And then the flow lasts usually between 3 to 8 days, and the quantity is usually between 30 mils to 80 mils.
I don't know if anybody has ever measured the quantity.
It's something that can be estimated.
Okay.
Usually, how we ask women is to know the number of flow.
Okay.
For example, the woman changes pad that is moderately so twice a day for 2 to 3 days. That's supposed to be normal.
Okay.
But if a woman now begins to have menstruation that she has to change her pad about 4 times in a day for about 5 days, and experiencing clots, we know that it's becoming heavy.
Oh wow, okay.
So that's how the abnormality of menstruation starts.
So
also,
3 to
8 days.
8 days is normal.
Yes.
Okay.
So if the menstrual flow is getting beyond 8 days, we know it's getting abnormal. If it's getting below 3 days, we know it's getting abnormal too.
Okay. So now the total cycle now is how many days on average? I know.
No, we say 3 to 5 days generally.
No, I mean this total cycle.
The cycle length.
It's now 28 days or 20.
No, when it comes to length, the average is usually 28 days, which is the common thing we know.
Okay, 28.
But when it comes to the interval between period, the range is actually between 21 days and 35 days.
Okay, 21 to 35 days.
So
okay.
if a menstruation occurs, the interval is up to 21 days in between. It's still normal.
Okay.
If the interval between menstruation is around 35, it's still normal.
All right.
Some people will tell you that, oh, I've seen my menses twice a month. You have to ask a question. Is it really quite a month? For example, somebody, the last menses started maybe
First.
Something like around first, second, or third, and the next one started around 27, 28, 29. That's still
Okay, it's still within the time. You have a shorter in
the
between.
interval.
Okay. Interval is shorter.
Still between, once the interval is between 21 to 35.
Okay, I just wanted to clear that because some people will be thinking when they say monthly flow is 30 days you're looking at, and then
28 days usually.
Okay, the 28 days. So,
Yes.
but you can have between 21
and 35.
And 35.
And it's still normal.
Okay.
Yes,
And then the number of days for the flow
between 3 to 8 days.
To 8 days. Okay,
Yes.
so it is normal. All right, and then the flow should be,
Yes, like your part, let's say 2 to 3 parts in a day.
Okay.
For about 3 to 4 days, it's okay.
Okay, it's okay.
All right.
All right.
That's
So
okay.
it's just to clear on what is normal.
Yes,
Accepted
first.
normal. Yes.
That's what is
Okay.
expected.
All
normal.
right. Okay.
So, when it comes to abnormality of hormones in female, if, just like we said, there is either heavy menses or unduly long, prolonged menses, what we call menorrhagia, is when you say menorrhagia, it could either be due to the quantity or the number of days.
Okay.
If it's very heavy with clots, it's menorrhagia. If the number of days is more than 8 days, it's also menorrhagia.
Okay.
Then, if a woman sees her menses and interval between menses is more than 35 days, we say it has become oligomenorrhea.
Okay.
And this one usually is common with one of the commonest form of hormonal imbalance in women, what we call polycystic ovarian disease.
Okay.
So that's syndrome. That's
one of the symptoms. Okay.
This one of the symptoms is on the prolonged interval between period, usually greater than 35 days. But the limit is actually 6 months.
Okay.
For that
to be diagnosed.
Yes.
Okay.
Once the menses is now becoming longer than 6 months, it's no longer oligomenorrhea. We call it, and if there's no pregnancy, we call it secondary amenorrhea.
Okay.
That means there's absence of menses.
Okay.
Yes.
Okay. All right. So I'm just trying to get everything wrapped together. Now, you talked about clot. Every lady who menstruates should see a little bit of clot, or it should not be there. If it is there, then there's a problem.
Most of the time, there's no clots.
Okay.
It's just dark and
yes.
soaked, just flow. It's when it's becoming heavy that it has time to clot, and when the coagulative factor become deficient, that's when it becomes clotted.
Okay.
So most of the time, naturally, it's not usually clotted.
Okay, so if it's for 3-4 days,
yes.
But if in the 3-4 days, maybe you notice some form of does the color? I'm just trying to bring out a lot of things. The color in the blood tell anything? Does it? Are you looking at my blood is darker or my blood is?
No.
It
That one
does
is
necessary.
No.
Okay.
It's just most importantly the number of days and the quantity of flow.
Okay.
Are you changing your pad? In fact, some may not even have to even use 2 pads at a time. Some may not even be able to use pad again.
Okay.
So that's when we say it's heavy.
Okay, it's heavy.
Yes.
All right. So I like the fact that we have cleared a lot of that. So what every lady should be looking at is your period is not exceptionally longer than 8 days, and it's not less than 3 days. Okay. So if it's less than 3 days, you should now be complaining.
You should let your
gynecologist know, especially if you've had the first time, second time, third time. And then if you're not seeing your period at all for a long period, you should see your gynecologist.
Yes.
And then in between is 21 to 35 days.
That for the
normal range.
Yes,
so when it starts going below 21,
it's abnormal.
It's abnormal. And if it's over 35,
it's also
abnormal. Okay, so that I'm sure my viewers have gotten what we're talking. So if you notice anything, please see your gynecologist, doctor for early. Okay, you mentioned something on PCOS, that is polycystic ovarian syndrome.
Yes.
I've been hearing that a lot now. But before I even talk about that, something has been on my mind. Why is it that we are having these issues of hormonal imbalances on the rise now? I couldn't really find statistics to show what it was before or what it is now. Is it that okay, we have more research now, or what is going on? Are we eating wrongly? Are we what is happening that now it's becoming this? You're looking at PCOS, all these hormonal imbalances, they become high, and not just for female hormones. You're also talking about other hormones in other areas. So what is going on? But of course, we're focusing on women today. So
Well, one thing is the lifestyle changes,
okay,
and also the fact that nowadays onset of reproduction of giving birth is women are now is not at an older age compared to before. All those
okay.
and also because of availability of diagnostic equipment for some of
okay,
these things.
okay,
So that's why it's not that for that of hormonal imbalance, not that it's so much different from what it was before.
Okay.
Yes,
So what it is, there's always
yes,
pretty much what it has
yes,
always
yes,
been.
yes, for
Okay,
that
but
particular
okay,
disease, yeah.
but it's still good to eat healthy diet as a woman. and
Yes,
eat well. You know.
because by the time we start discussing this polycystic ovarian syndrome, we discover that the lifestyle changes can affect that one.
Okay.
All right.
All right. So we're going to shoot to the polycystic ovarian
Yes.
syndrome. Now, I know it's common. You know, I know people that have come out to talk about how they battled with it. It made it difficult for them to even have children or get pregnant. You know, and they say some people they told them outrightly that you're not going to have kids. And so, what is PCOS? Just in case somebody doesn't even know what they're going through at the moment.
PCOS simply means polycystic ovarian syndrome.
Okay.
I discovered that the young ladies of nowadays, they even have a good acronym for it, PCOS.
Oh, okay.
PCOS.
Oh, because yes, of
Yes.
course.
The P for
PCOS,
polycystic.
then
There's the P for polycystic ovarian syndrome. Yes. It's something that affects about 6 to 7% of the general population of women of reproductive age group.
okay.
But when it comes to women that are having fertility issue, it could range up to between 15 to 20%.
Wow. Okay.
Yes.
Wow.
And it is an hormonal imbalance. Is it hormonal imbalance?
Okay.
And what happened is this, that it's not a disease per se. It's just a variant of normal of the appearance of the
Okay.
hormone
Okay.
of the ovary. Which you know, when the ovary, when you look at it, what does it look? What does it mean? Is that when there is PCOS, usually the woman present with unusually long time interval between periods.
Okay.
Some may see their menses maybe every 40 days, 45, some twice in a year.
Okay.
So
Twice in a year.
yes, that's
Oh, wow.
one of the commonest symptoms. Then we also discover another thing is that it's common among people that are obese, but it also affects the ones that are going to have normal BMI.
Okay. Okay.
Also, there is association with hirsutism. That means usually male pattern of woman hair growth.
Okay. So, women that have growth.
Hair growth on
Okay,
the
unusually,
chin,
yes,
on the
yes,
face,
yes, yes.
on the hair. Sometimes the pubic one is just appearing like a man instead of
Okay,
the
okay.
hair growth there.
Okay.
So the hair growth, that's what we call hirsutism.
All right. Okay.
It can also change their voice.
All right.
And people with that have PCOS, that's because also there is association with diabetes mellitus.
Oh wow.
By the time we are talking about the treatment, there is association with it. We'll be able to bring it because it affects the insulin metabolism. So by the time we are discussing the treatment, we'll be able to get into this.
Into the details of it.
Yes.
So these are the things the lady will notice, these symptoms. So you're looking at hair growth and unusually long periods.
Interval between periods.
Okay. And then any particular thing with the period, is it heavier? Is it?
Because it takes a long time before the next period. The next period, the period may also be heavy.
All right.
And you know, just like having a field that you used to cut every three to 4 weeks, yeah, you leave it uncut for about
to be more.
4 months. you see that they are going to be, it could be heavier too. So at the same time, part of me looks sometimes it will now be heavier because of that reason. And usually due to abnormality in hormone, just like you've said, the interplay, hormonal interplay in women is from the brain.
Okay.
The hormones, they are released from the brain, acts on the ovary to produce all the estrogen and progesterone you are talking about earlier,
yes.
and which in effect acts on the endometrium in the uterus.
Okay.
That leads to the growth.
All right. So there's a problem with those hormone
So
releases.
at the pathway of the brain, if there are three hormones that are important that are produced in the brain when it comes to menstruation. Number one is what we call the luteinizing hormone.
Okay.
Produced in the brain, follicular stimulating hormone,
FSH.
and the prolactin.
Prolactin. Okay. Okay.
And this, let me also chip in. People with PCOS, they could also have milk discharge
okay.
without being pregnant.
Oh, okay.
What we call galactoria.
Okay, okay. So which means there's, at least I know this one, there's a high level of prolactin.
Yes.
Okay, okay.
So if the level of hormone produced in the brain, the LH, usually there's a balance between the LH and FSH
Okay.
that leads to normal menses. Let me put it this way. The ratio between LH and FSH in the body under prior to immediately before menstruation, immediately during menstruation, is usually the FSH is usually higher than LH.
Okay, before menstruation.
Yes, just around that menstruation. That's what
okay, okay.
Now, if you take the sample, you discover in those people that because the LH will now be reversed higher than.
All right.
And this one leads to producing more of androgenic hormones.
Okay.
Remember that estrogen and progesterone
yeah.
are more of feminine hormone.
Yeah.
Women with PCOS, because of this abnormality, the higher level of luteinizing hormone, it leads to androgenic hormone being produced, all this increase in testosterone level,
all right,
which can account for the hirsutism we may have, the acne.
Yeah, the seasoning hormone, the seasoning menses.
And other things.
Now, you just talked about acne, because I know lots of, it's normally a problem with many women. Is that part of it? The hormone could be responsible for what we call pimples.
Yes. If a woman is discovering that she's having delayed menses, you see, acne being common, though it's common in teenage age usually.
Okay.
Combined with hirsutism and sometimes with breast milk discharge. That woman should be screened for polycystic ovarian.
All right.
syndrome.
Okay, because what the problem is now is you're producing more of hormones that
are masculine
in nature.
Yes,
okay.
the androgenic hormones.
Okay. Oh dear. So that's why it becomes even difficult to
menstruate and other things, because the interplay between the estrogen and progesterone will be masked by the.
Okay. I know you're struggling so much not to make it too medical. But yes, I understand. So that makes a lot of sense now, why PCOS is a big problem. So these are the symptoms, and then a lady is looking at it and she goes to the gynecologist. So what is expected,
No, when a lady presents, usually one of the most important is still that history we are talking about.
Okay.
That will give the doctor the clue.
Okay.
I've not seen my menses for the last 40 days, 45 days, 2 months.
Okay.
You
do
have any unusual growth in your body? Oh, yes, there are a lot of hair growth in my tummy. Sometimes you will see it even on the face, right in front of you. Acne, and then you ask the question about whether there is making discharge. Oh, there is making discharge. Those are pointers.
Yeah, okay.
Then you want to go out to go and do investigations, both laboratory and radiological.
Okay.
2 important ones is the hormonal test and the radiological, the ultrasound.
Okay.
For the hormonal test, it's usually done on the 2nd or 3rd day of menses.
All right.
Then there's another one to be done on day 21, but the most important one is that date.
That first one.
The luteinizing hormone the follicular stimulating hormone, and the prolactin.
Okay.
Some can be the second or third pregnancies. That one, just like I said earlier, when we discovered that the LH rise higher than normal, is higher than normal, and also the ratio of FSH to LH, which is supposed to be 2:1, may be reversed.
Okay.
Then the classical finding, which is cannot be missed, is at the ultrasound. In which case, when one is able to visualize the ovary, one will discover multiple cysts forming like a ring around the ovary. Tiny, less than usually around just some few millimeter, less than 1 centimeter. You see it around it like a ring in the ovary, usually more than 8. Once you are seeing those small, tiny follicles, more than 8 in the ovary, one ovary, it says
confirm,
Yes.
But does it just start, or is it hereditary, or something is responsible, or it's just nature? Or
That is not, it's nature.
okay.
But one thing is sure, it's associated with obesity, just like we mentioned. If a woman with a BMI of greater than 25 is at a higher risk, though those with 21, less than 25, that is normal, can still have it.
Can still have it, but
and we also discovered that when a woman has lifestyle changes by reducing the body weight, it can also restore the message to normal.
Oh, really? So
yes.
if you exercise and lose weight,
yes, exercise, dietary control,
okay,
avoid late night eating, junk food.
Oh, wow.
Which is one of the first advice and treatment modality.
Okay.
Lifestyle changes.
Okay, that's part of the thing they treat.
Yes.
All right.
I remember a lady that I managed about some years ago. I think what when we saw her, she may never see her message for about 6 months. Even after all the drug, the thing still persist. But one thing we noticed, no matter how much she tried, the weight did not drop. Unfortunately for her, I think there was some social problem with it. She traveled and had rest of mind, was able to exercise, regain weight, it returned to normal. So lifestyle changes is one of the mainstay.
Okay.
Of
one of the main treatments
yes,
for management this thing.
Yeah.
But there is no case where there's nothing you can do about it.
No, there's always a way. In medicine now, especially when it comes to fertility, when it comes to most of this hormonal problem, there's always a way out.
Okay.
One of the things that brings them to the hospital is also that if they could not conceive, and there's always a way out of fertility nowadays.
Okay.
So when it comes to treatment, after the lifestyle changes, there are other steps you could take.
Okay.
You have to find out, is the woman ready for conception or she's not ready for conception? Are you going to address the fertility problem immediately, or you just want to address the physical, external symptoms?
Okay.
Because there could be, no woman would like to see people with all the hair on her chin and her facial hair.
So you can reduce that as well.
Yes.
Because I know a couple of people that complain.
With laser and medications.
Oh, wow.
That one could help to handle that esthetism.
Okay.
Then the symptoms like galactoria with drugs, that's breast milk discharge or watery discharge from the breast, could be handled with hormones, another hormones. They are common there. The next thing you want to ask is, for regulating, there are other drugs that are available. In some, we use some of the family planning pills, but not usually recommended. It's not a top priority on it. The other thing we could do is that for a woman that wants to get pregnant, let's concentrate on that.
Okay.
The way out is ovulation induction. Let me emphasize this. It's not all women with PCOS or polycystic ovarian syndrome that will not be able to get pregnant.
Okay, not all.
Not all.
Okay.
The only problem is that you may not be able to time your menses and your sexual.
Okay, your ovulation, your day of ovulation. Okay.
Meeting with your spouse.
Okay. Oh, I understand now.
I hope you get that.
Yes, I understand now. Yeah.
You discover that some with, because they may even be seeing the other once in 2 months, once in 3 months, and they're giving birth to 3.
Because normal people know that on particular days,
And
yeah.
that's why the best advice for couples when they get married is for them to meet on average of 3 to 4 days. So no matter the time the ovulation will occur, there's a high chance of getting pregnant. So we should get that clear.
Okay.
It's not all women with polycystic ovarian syndrome that will not be able to get pregnant.
I'm glad you're saying this, because most people that hear that word just conclude that, look, I'm done. I'm going to be infertile for the rest of my life. Yeah. Okay.
Then the other thing about it is, those for the remaining part that want to conceive, we can now use ovulation induction.
Okay.
There are a lot of them that are available. We have the clomiphene citrate.
Okay.
We have the letrozole, which is nowadays preferable to the clomiphene citrate.
So, but all these things should not be taken out.
Without
you must be with the gynecologist.
We must be with the formula, and after other causes of infertility has been screened out.
Yes.
The man is okay, the tube is patent, ovulation induction. If that polycystic ovarian syndrome is the only cause of the infertility.
Okay.
Then there is something that I must mention, which I've seen a lot of people coming to my clinic and say, look, I can't believe the doctor gave me a drug that is used for diabetes for treating this, and they get annoyed. We also use what you call metformin.
Okay.
It's a drug for diabetes, but can help to correct polycystic ovarian syndrome.
Oh, wow.
And improve fertility.
Improve fertility. Oh, wow.
Yes. You remember that we said there is a link between polycystic ovarian syndrome, obesity, and also diabetes mellitus.
Yes, yes.
So, with the interplay of that metformin, it helped reduce the androgenic hormones.
Okay.
And increases chances of ovulation. And that is why a woman should not be surprised
if
she
prescribed
that drug metformin.
Okay.
Sometimes it will be given in combination with one of the other ovulation induction drugs.
Okay, about all these things, which is most important, is you must be working hand in hand with your gynecologist. He's the one to make the recommendation. Yes. Okay.
And there is another method, a surgical method, what we call ovarian drilling. It's a laparoscopic procedure.
Okay.
And there is a way to be handled. It's not something that is a little bit technical that could be done, whereby a procedure will be carried out laparoscopically on the ovary, and it will make the ovary to be more sensitive.
Okay. Make the ovaries more sensitive.
Yes.
Oh, wow. Okay, now we're going to go on a break, because we stay on this PCOS for a while. We're going to go on a break, and when we come back, we will talk more on PCOS and then move on to other disorders that are hormonal. So, all right, viewers, we'll be right back. Okay, so if you see, is it okay, all right, no problem. Okay, she was asking me some questions. If age is, but we'll talk about it. If age contributes to it, since you talked of obesity and all that, then okay, I'm sure you'll be able to answer. 21 minutes. Wow. Okay.
I don't have this.
We spent 30 minutes already. In the studio,
Okay.
time is short. All right. Okay. Welcome back, viewers. Before we went on the break, we were discussing female hormonal disorders, and my guest is still Dr. Nathaniel Adewale. He's a consultant gynecologist at the University of Abuja Teaching Hospital. Thank you so much, sir. You know, I've learned so much from this our discussion today, because really, all the while I've been hearing PCOS, when people say it, it's like it's the end of the world, you know. But I'm glad today that there's somebody watching, and maybe your friend have told you, if you have PCOS, you won't have children again, you can't marry. In fact, I know somebody that had to end their relationship because they felt the person was never going to have children. But thank God today, with this knowledge you're passing to us, anybody that is watching, there is help, there is solution, and you can have your children and you can be well, just to do the right thing with your gynecology. So thank you so much for the information. We talked about people, if you're on the big side, obesity, there is the correlation, there. But how about age? Is it, can you find out when you are older, or it's always there from the
It can start anytime.
It
can start anytime. Though when it starts, at the beginning of menarche, when a woman sees her first menses called menarche, at that early stage, usually women can have irregular periods. May even skip 1 month, 2 months.
Okay.
So that's why we don't usually diagnose it very early.
Yeah.
But when the woman is already approaching 19, 20, and yet has unusual menstrual delay, then we start suspecting that. Let me also, this undue worry. I had a woman that had PCOS. She had 3 children without using any medication.
Oh, wow.
In fact, what brought her to me, I knew she had it, was the fact that she could not have a major child. She now thought it's because of the PCOS. And I said, no, it's not because of it.
Okay.
And it took me time to convince her.
Okay.
No,
so she couldn't have a, she thought she couldn't have a male child.
Yeah. So
this is some of the misconception. It's not
true. It's a misconception.
Yes.
But definitely a lot of them, the most important thing that for those that are married, they should meet frequently.
Okay.
So that anytime the ovulation occurs, since you can't predict it, they can meet. That's
especially
the most important
if you have the longer in between.
So age, it can occur. You can see it in young, you can see it in late. Anyhow. Yeah.
Okay. What of people that see only 2 days of period? Should they also be concerned? I don't know if you've seen such cases where your period is 2 days, some days 1.5 day, and you're...
Yeah, if it's 2 days, and it's up to about, you're changing pad about 3 times, I may not worry.
Okay.
But 2 days, I'm just more, light, the one is getting worried. That one may not necessarily be hormonal. Okay. There are other causes of those kind of menses. That's what we call scanty menses.
Okay.
Hypomenorrhea. The menses is scanty.
Okay.
That one is usually not due to hormonal imbalance.
Okay.
It could be due to something like less overcorrecting of the endometrium, during the producer like DNC, or abortion that is not well managed.
All right.
Miscarriage that get infected. Or during post-operative. That one
but
is
if you notice it, you should still see
you have to see your gynecologist.
If
you have to see your gynecologist.
That your period is scanty and less than 2 days, 1.5 days, you should see your gynae. Okay, so the PCOS, so there's solution.
There is solution. PCOS. Just let me summarize the solution.
Okay.
1, lifestyle changes.
Okay, very important.
Very, very important. For people that are not married, no fertility is not their problem. If there is a symptom, any of the symptoms can be managed. Like the hirsutism, this unusual hair growth, waxing, laser could be used to address that.
Okay.
Those that are having recurrent acne can see their dermatologist.
Okay.
Those that just want their menses to be a little bit more predictable, hormonal interplay, the doctor, your gynecologist will know what to give you.
Okay.
Then those people that have problem of infertility, first of all, the husband and the wife will be investigated. Other causes of infertility will be ruled out. If it's just purely PCOS, ovulation induction. And some of the drugs are available. And I've also mentioned the fact that the use of metformin to augment those ovulation induction drugs.
Yeah, which is the diabetic, anti-diabetic.
Anti-diabetic, that is because of the link between PCOS and diabetes and obesity through the androgens. Through the hormones. So that one will help there. Also the fact that there is a laparoscopic means of what we call ovarian drilling.
That can make the ovaries more sensitive.
Yes, and those people that have tried or they don't want to do that, they can go straight for any of the assisted reproductive technique,
That's in vitro.
in vitro, and other things.
Okay, and other things. Okay, so there's a solution.
That's
for
the
PCOS.
solution.
So if you have that, it's not
Yes,
a infertility for life. I
No,
can't
no,
have
no.
children. There's solution. All right. Okay. So at least we've talked about PCOS. I've really enjoyed the talk on PCOS, and I'm so happy
That's good.
about clearing the air on that. Then let's talk about ovarian cyst. Some people
Yes.
call it follicular cyst. And I have a friend who had a surgery, wanted to take out the ovarian. It was really large, and I'm wondering, why would you get a cyst? Does it just happen, or we are doing something wrong again?
Ovarian cyst is different from follicular cyst.
Yeah.
It's a form of ovarian cyst.
Okay.
Follicular cyst means that they are just follicles, either the normal one or the one that have become bigger. But we notice that this physiological cyst, let's use the word physiological cyst.
Okay.
We have follicular cyst, which is the one that every month gets big. At around mid-cycle, it's ruptured to release the egg. That's follicular cyst.
The follicle is the one that holds the egg, the ovum, and then releases it in, and then shrinks off.
Shrink up by the, and then towards the end of the, then once you shrink up, no really production of progesterone again in the luteal phase. The woman sees her menses.
Okay.
Then we have physiological cysts. These are cysts that occur. They just grow abnormally.
Okay.
And usually they are cysts between that 1 centimeter to less than 5 centimeter.
Okay.
Most of them, they will disappear on their own.
All right.
Without any medication.
So cysts are not, most of the
Not all cysts are pathological or something to be worried about.
All right. Okay.
But when a doctor sees a cyst and it's, let's say, between 1 centimeter to 4 centimeter, you can say, okay, come back in 2 months' time and check.
Okay.
A lot of them will disappear. But when it starts getting beyond that, it has become ovarian cyst that needs to be handled.
All right. Okay.
And some can be small, some can be big, and some may not be big and still give problem. Because even if it is just about 5 centimeters and it twists on itself,
okay,
it's become very painful.
Very painful, yes. It can
And
be
if
very
it's not,
uncomfortable.
if it's not handled, you know, it's when there is ovarian cyst and it's twisted the ovary. It can go to a level that it can cut off the blood supply to the ovary.
Oh, wow.
Yes, and it can become gangrenous. So when ovarian cyst is becoming painful, somebody has ovarian cyst and it's painful, it's not just enough to start taking painkillers.
Yes. Okay.
Evidence, the persistent pain is an evidence that is a torsion.
So this pain now, because I'm trying to think of how will somebody know, if you have the symptoms that will go on, the cyst that will go on its own, you wouldn't feel anything, obviously. I want to believe you won't feel anything.
Not necessarily. There are some that may be painful. For example, if the cyst is just about 2 centimeters or 3, and it becomes hemorrhagic, that means there's bleeding to it. The bleeding can be painful, but it can still resolve by itself.
Okay.
If it is small.
Okay.
It's not all the cysts that are greater than 5. Those are not the only one that give pains.
Let me just be clear. A cyst is different from fibroid, right?
If cyst is completely different from
fibroid. Okay.
If cyst occurs in the ovary, fibroid usually not 100% occurs in the uterus.
Okay.
Yes.
So cyst is in the ovary. Okay.
So to make it simple,
okay.
Follicular cyst is usually the one that contains the follicle. Physiological cysts are the one that, all these ones that are between 1 centimeter to 5 centimeter, that are just persistent. You can see them almost throughout the month. Then you are scanning, you see them. But as I said, quite a number of them will just disappear on their own. Okay. Without even taking any medication.
Okay.
The body has a way of manipulating its own hormone.
Okay.
Because hormone that usually sustain them to become big.
Okay.
But not because of a lot of it, not because of what you do, what the person did or not.
So then it's just because of hormones that interplaying with themselves. Okay.
Then the one that are 5 centimeters and above, or sometimes if it is less than 5 but it's painful, action needs to be taken.
Even as much as a surgery.
Yes.
Sometimes
it's surgery. Sometimes they could do what you call ovarian cyst drainage.
Okay.
Ultrasonic guided drainage.
Okay. Because we've advanced now, so we have easier ways to go about it.
Yes.
Yes.
And let me also mention that it's not all cysts that are simple. That's when when you do the scan on them, you discover that it's not only fluid, it's mixed with solid materials. Those ones are suspicious. It's better they are handled surgically.
All right.
Either by laparoscopic surgery or by open surgery.
So the cyst itself, it presents like a airbag or fluid bag, just fluid.
It presents like water inside a balloon.
A balloon, okay.
On scan, usually if every woman that goes for scan, they will know that the doctor will ask them to go and drink water. The essence of it is for your bladder to be full, which will act as a medium for this scan. So that water in the bladder, it makes it looks dark. So most of the, if there is a ovarian cyst that is just liquid, it will appear dark like that on ultrasound.
On the ultrasound. Okay.
Yes.
Okay. So now that one is what is present, but when it starts having other things contained
mixed in the
yes, but that can be seen when you go for your
scan.
For your scan. Now I'm just thinking, a woman, does she need to, in her reproductive age, does she need to have a frequency of going to scan to be sure that she's okay, or is it just when? Because most times, because maybe you're trying to have children and trying to check, that's when you notice. If you get pregnant immediately, you may never even go and scan.
The truth of the matter is that, in this part of the world, we are negligent about our health. How many people will have a car? You have a car, frequently do you service it?
At least every 4
you go and check something. Am I right? Is it car okay? Am I right?
Yes. Even when it's fine, so you just want to just
be sure.
Check.
No, check the tire for me. That's how we are supposed to do medical checkup.
So a woman should do this scanning frequently, or not frequently, even if it's
6 months or once
a year,
just as part of the routine medical checkup.
Because if you don't do that, nobody's ever going to know that you have a cyst.
Yes.
And then which means sometimes.
And you know the funniest thing, especially, it can be as big as 8 months pregnancy.
A cyst?
Without even giving any sign.
A cyst?
Yes.
Do you know when you talk of cyst, I always think it's just something very little.
It's that most of the small ones, that's what I said, disappear.
Yes, they can disappear themselves.
We've seen the ones that are bigger than 9 months pregnant.
That was
because most of the cysts may not even give signs except that abdominal distension. And before it becomes obvious, women has a way of hiding things under clothes.
Under clothing, yeah. Wow.
And also, even when they discover the fear of surgery, which is something we cannot, I want to encourage all media practitioners and any jingo. The aversion for surgery is causing us more problem in this country, despite the availability of knowledge, equipment, and manpower. Because some people, when they even have a seed that is still small, the next thing is that they will allow it to be dirty, it will go very big.
They rather want to drink something to flush it off than do the right thing to get rid of it.
All the herbal or drugs, or the drug they are taking, you go through the stomach and come out.
But that's the thing, because there's so much of it online. Drink this and the fibroid will push out, and as if the root is the same.
It's something very pathetic. I'm not against alternate medicine, but we have bastardized it to our own detriment.
Okay.
Anybody can just manufacture anything and say they cured this. And there is no law to checkmate. A lot of them will even do damage to other organs. They said you are drinking herbal drug to flush out cysts. How? Where will you go through? The most people is the unregulated aspect of it. And this thing runs to thousands of naira, more expensive sometimes than the surgery.
The surgery itself.
Yes.
So when there is a case for surgery, surgery is not a death sentence.
It's not.
Because I think there are too many stories out there that the negative part of things as opposed to the positive part of things. People, if something goes wrong, everybody's making this, they didn't do, but nobody ever goes on to say, they did my surgery and it was successful and it was easy. Thousands, yeah.
Thousands will have done.
Yeah.
Been done without any mortality, and then just
one, and
which could be due to other
issues,
existing morbidity. So this issue of cysts every woman should, up as part of their routine medical checkup, do regular scan.
Okay.
They will look at the size of the cyst and what is the content. Is it just liquid or is it mixed, solid? There is a way solid structures.
Yes, it becomes harder.
Rather than it appear what we call become opacified even on scan. So those are issues.
Okay, so let me just. I know I advocate. I think you should do the test, but I'm not thinking symptoms. Are there any symptoms apart from the pain? The pain is normally like menstrual.
Usually, the common pain is not the first. It's usually the the swelling.
But by the time it's swollen, it's already.
Some of them will be big, and the bigger one may not even be painful.
Oh, all right, okay.
Most of the big ovaries are not even painful until either they become twisted or infected.
Okay. So if you notice bloating or
yes, you should do scan. Then if there's the usual pain, then they should also.
So where is the pain localized? Is
it can be
anywhere?
Yeah. And there are other structures in the abdomen. Let me give you an example. On the right side, around the side where the ovary is, that's also where the appendix is.
So sometimes you can confuse.
Yes, but of course, scan will pick it up once.
Pick it up, yes, once, yes.
Yes.
Okay, so it's very okay.
And also by the appendix, usually even by physical examination, we give it out.
Okay. So one thing I'm taking away from this discussion today, I know we talked about PCOS, which has really cleared a lot of things for me. Then from this cyst, you brought up something very important. The importance of scan for women. Your routine medical checkup.
Checkup should include
scan.
And as I've said earlier in the previous episode, including pap smear for women of reproductive, for women that has.
Okay, of reproductive age. Of course, yes.
Or even post reproduction too.
Okay.
Pap smear, your routine medical check should include scan and pap smear.
Wow.
For women.
Okay. At least once a year you should check.
Yes, once in a year.
Because some of these growth take a while to grow.
Yes.
So sometimes they've been ignored for long.
Let me also mention this.
Okay.
For those women that are not of reproductive age group, any cyst, ovarian cyst of any size is significant. Women that are not of reproductive age group, any cyst of any size is significant and action should be taken early.
Okay. So whenever anything can be discovered even when you're younger.
Yes, at the young age we can have this follicular cyst, physiological cyst. Some of them will disappear, but after the reproductive age group, no ovarian cyst should be taken lightly. Okay. Need immediate action.
Okay, so
for that test and proper adequate action to be taken. Okay,
so it's when you see your gynecologist, then they will know what to do with your case. But the thing is, the beginning is the protruding stomach. But even most time, when your stomach is already protruded, it's already advanced.
It's already advanced.
So the general makeup should pick up some of these things when you go.
Routine medical checkup. Ultrasound will pick it up early.
Pick up all of this. Okay. So I wanted us to talk on amenorrhea, but we've talked on it because we don't have any more time to talk on the amenorrhea.
That's a wide topic. I think you have to just create.
I have to call you a day and you come back again.
No, that amenorrhea is so wide.
Yes, okay.
And so many issues around it that it requires a whole episode of its own.
To discuss. So I'll call you in. So one thing again that I've learned is the acne. Sometimes it could be hormonal.
Most of the time it's hormonal.
So
if you notice, it's very common among the teenage age group.
Yes, when you're just
time. Yes. Pubertal changes.
Yes.
It's hormonal changes.
Yes. It can be very embarrassing because some people can be so much, some people.
Women they don't take their facial appearance to be.
Of course. No, I don't think you must be looking at somebody's face who has all this acne all over.
Beauty is in the hand of the beholder.
All right, thank you so much for coming on the program today, sir. I think I've learned so much. PCOS, the importance of that routine medical checkup, including ultrasound for the woman.
Yes, because of the cyst.
Okay, because if not, because when you're pregnant, that's when they pick up some of this. I think most people don't even know that there's anything.
Or when they are investigating them for infertility.
That's when they find out that, I think I'm even guilty of that kind of thing. So I think it's important to take that seriously to check. Thank you so much, Doctor, for coming on
It's
the
a pleasure.
program. I always like when you come around because I always learn a lot. But I'm still going to call you back again for let's talk on amenorrhea. We'll talk on we've done a bit on fibroids, but I think we'll talk on it, the endometriosis. There's quite a number of things I need to drag out from you. And
Anytime.
yeah.
It's part of our service to humankind.
Abi, thank you so much.
Thank you.
You so much. And
Well done for the good work, job well done too.
thank you, sir. And to our viewers, thank you so much for staying with us. I know you have learned a lot today, just as I have. Now, one thing I'll take away today is PCOS is not an infertility castaway. It's not that there's no hope. There is hope. You can go to your gynecologist and you will get help. They'll find a way to help you. And the importance of medical checkup, very important, very important. This is where some of these issues are picked and dealt with immediately. Thank you so much for spending this time with us. I'll see you up. For the past couple of minutes, we've been speaking on female hormonal disorder, and my guest on the program has been Dr. Nathaniel Adewale. He's a consultant gynecologist at the University of Abuja Teaching Hospital. He's a very popular face on this program, so you still see him again to educate us. And my name is Angela Emeka Ebibo. I'll see you next time. God bless you. Goodbye.